So, as a matter of fact, patient safety during surgery dramatically improved, I would say, over the last 50 years. And today, very few patients die during surgery. But we also know that still over 4 million patients die every year within 30 days of surgery. We know that from a study published in the Lancet a couple of years ago. And many of these patients die on surgical wards, where clinical deterioration may be detected with a delay or because of the intermittent nature of nurse spot check. As you know, nurses usually spot check vital signs every 4 to 8 hours. And we also know from recent studies that by doing so, they may miss a significant proportion of adverse events. For instance, I have in mind a recent study from the Cleveland Clinic where nurses were spot checking vital signs every 4 hours and showing that they missed 80% of hypoxemic and hypotensive events. So obviously, if we were introducing continuous monitoring on the wards, on regular wards, that would be the opportunity to detect clinical deterioration early, and that would be a major opportunity to improve patient safety. So as a matter of fact, several large studies have already reported clinical benefits after the implementation of continuous monitoring on medical or surgical wards. Most of these studies reported a decrease in rapid response team events or rescue intervention, a decrease in ICU admission, and some studies even reported a decrease in hospital length of stay and mortality. These are large before-after studies, not randomized controlled trials, but I think they're useful to assess the impact of continuous monitoring in real-life conditions. So clearly, it's not only about the sensor itself, it's a lot about connectivity and the ability to filter artifacts in patients who are going to leave their bed. It's also about the appropriate and timely response to the alarm. It doesn't make any sense to detect clinical deterioration early if the timely and appropriate response is not following. So it has to be defined very clearly who is going to react, who is going to be informed first, and what should be the response. And what's very important, of course, as well, is alarm management. The goal is definitely not to increase the number of alarms, and particularly the number of false alarms and alarm fatigue. So to do so, we need to rethink alarm settings. For instance, we need to personalize thresholds. There are not two patients alike. So a patient with COPD, for instance, would not make any sense to ask the system to alert as soon as SpO2 is below 95, or a patient receiving beta blockers as soon as heart rate is below 60. We need to personalize thresholds. We also need to increase the time interval between the detection of an abnormality, an abnormal vital signs, and the alert. And that's something acceptable in the wards. 5 minutes, for example, of annunciation delay would be acceptable in the wards, not in the OR, but definitely on the wards, where we should keep in mind that today, nurses would anyway spot check vital signs only every 4 to 8 hours. And recording a vital sign continuously or almost continuously over a 5 minutes period and using the median value is actually a very basic and very simple way to eliminate most artifacts. What's very important as well is to consider patient comfort and satisfaction. And I think, and I know most of these new monitoring systems, took into account these factors. What I mean is that alarms should be excluded from the room. The goal is not to annoy patients and to disturb patients to increase their level of stress. Alarms have to be sent, have to be seen and heard at a central station or directly on the smartphone of the nurse, but not in the patient room. And so patients should be able to recover in a quiet atmosphere. I think it's very important as well.